Okay, we're going to get started. It had 7 o'clock. I would like to welcome everyone to this evening's medical grand rounds from the Royal Victoria Regional Health Centre. This is a unique grand rounds. Usually we do this in a full auditorium at lunch with pizza, and we still do broadcast it out to OTN, but obviously due to the current situation, Dr. Igrick will now present to a nearly empty auditorium. There are 5 people in this auditorium. And it'll be webcast out across the region and anyone in the province looking at it. Hopefully everyone was able to log on and has the Slido app or the Slido website open to ask any questions. My name is Chris Martin. I am the Chief and Medical Director of Critical Care here at Royal Victoria Regional Health Centre. I'm also the Director of Education, so I coordinate with my team rounds, lecture series, etc. It's my pleasure tonight to introduce my colleague, Dr. Anna Igrick, who will be giving a very obviously timely talk, and I think a necessary talk, as we all have to step up in the face of this pandemic. And so her talk this evening is, of course, critical care for the non-intensivists. In true Dr. Igrick style, it'll be knowledgeable, practical, and I think everyone will find it very useful. So a little bit about Dr. Igrick. She's a general surgeon as well as a certified intensivist. She trained in London, both general surgery and critical care, and we recruited her up to Barrie, I think, about 5 years ago or 6 years ago, about that. And she's been a valuable member of our team ever since. Anna has a special interest in humanitarian medicine. She was actually just finished her diploma of tropical medicine and hygiene in Peru, and literally managed to get out of Peru the day before they closed the borders to the COVID pandemic. So we're lucky that she got out when she did. I'd like to welcome her tonight to speak to you. One question with the Slido questions. Text them in on your phones or online. We will answer them after. We also have Dr. Giulio Diodato in the audience, who's on call tonight, but he's obviously an expert in infectious disease as well. So between the two of them, I think we're very well covered tonight, and it should be a very educational evening. So without further ado, we'll give a very warm round of applause from home for Dr. Igrick.
Thank you very much, Chris, for that kind introduction, and thank you for the opportunity to give these virtual grand rounds. So the idea for this talk came from 2 sources. One was after leaving Peru, I found myself in quarantine with 2 weeks with a lot of free time, which lent itself to a lot of reading and reviewing of the literature, like a lot of you. And the second inspiration was my colleagues here at Royal Victoria Hospital. I've had countless specialists, from surgeons to oncologists to radiologists, ask me, teach us about critical care. What do I need to know? How do I run a vent? So this talk was born out of that interest, and hopefully will be helpful, especially for those people who may find themselves helping out in the intensive care unit. So the objectives for tonight are threefold. We are going to review a clinical case of a patient with COVID-19. I'll provide a brief overview of COVID-19, which is probably going to be a review for all of you since, like I said, there's been so much information in the last little while. And the bulk of the talk will focus on ICU management for this patient. Keep in mind, information is changing daily. There has never been such a plethora of papers and evidence coming through. So this will be kind of a broad view of some strategies for ventilation, ARDS, hypoxia, hemodynamics, and some adjunctive treatments for this group of patients. So we'll start off with a case. And this was a 41-year-old patient who presented to our center here at RVH with signs and symptoms of potential COVID-19. For past medical history, this gentleman was quite healthy with just a remote seizure disorder and a slightly elevated BMI. In terms of the history of the presenting illness, he had had 5 days of shortness of breath, somewhat of a dry cough, and a fever. And with this, he had 1 day of some loose stools. This here is just some data I extracted from this chart to show you his initial vitals when he presented. He had a low-grade temperature of 38.1, heart rate of 107, increased respiratory rate at 26, and standing 90% on room air. So this patient was assessed quite quickly, and within about 3 hours is the difference between those sets of vital signs you see there. He had been seen by medicine where he showed no acute distress, no use of accessory muscles, and he had some decreased air entry bilaterally with some crackles. Vital signs had changed slightly for the worse, as you can see, with a slightly increased respiratory rate, saturations that were 92%, but now on 12 liters of by oxymask. In terms of investigations, I just picked out some pertinent points. You can see there that his white blood cell count was essentially normal, but his lymphocytes were 0.92. I must admit, prior to the COVID pandemic, I didn't often pay attention to lymphocytes. However, from studies coming through, lymphopenia, as is seen here in this patient, has some significance and is quite common in these patients. He also had a slightly decreased platelet count. Here we see his venous blood gas, which is more or less normal, perhaps slightly increased pH, and he's breathing up quickly, so slightly decreased carbon dioxide. Okay, so those were some. Here's another pertinent investigation he had. This is the chest X-ray, so you can see very non-specific, some bilateral infiltrates, more so on the right side. And this is the chest X-ray the day after admission. So again, you can see decreased lung volume, some atelectasis, and more infiltrates. So at this point, the patient had been admitted to the internal medicine service. We at our hospital are fortunate to have a critical care outreach team, and the patient was consulted for increasing oxygen requirements. At this point, he was transferred to a negative pressure room for Optiflow, or high flow nasal cannula. And by 10 a.m. the following morning, he was already on 75%. For those in the audience not familiar with high flow nasal cannulas, it can go up to flows of about 55. It's humidified and warmed air. And initial guidelines in this pandemic had suggested against its use, but further data has shown it to be quite helpful in the subjective dyspnea, as well as potentially delaying or avoiding intubation. However, in this patient with the increasing oxygen requirements, he did require intubation and was transferred to the intensive care unit. So we're going to get back to this patient at the end of the presentation, but for now we'll do a very brief overview of COVID-19 or coronavirus. So coronaviruses are a large family of viruses. This family includes the virus, or includes illnesses such as the common cold and other illnesses that everybody is familiar with, such as SARS in 2003, MERS in 2012. And in fact, from looking at the sequencing of this virus, it is somewhat similar to the first SARS virus, and the name COVID-19 comes from coronavirus disease 2019. So I'll just simply be referring to it as either coronavirus or COVID-19. So this is the structure and the reason for its name of corona is crown. It is a RNA, positive sense single RNA virus of zoonotic origin. There's still debate what zoonotic origin. Did it come from a bat or where it came from, but it's believed that it is zoonotic. And what's also not known is whether it was pathogenic in the animals and then transferred to humans or mutated and became pathogenic. To be determined. So in terms of the clinical disease, interestingly enough, some patients may be asymptomatic, and it is unclear whether these patients can transmit the disease, which is why the focus on wide testing. The range of patients who are asymptomatic is quite wide, and it depends again on testing. So initial reports had said 1.7%, up to 17% on Diamond Princess cruise, and then later reports with more comprehensive testing indicated we may be missing a large proportion of patients who are in fact asymptomatic just because we're not testing asymptomatic people necessarily. The incubation period is usually about 4 to 5 days. So incubation, so from exposure to the virus to development of symptoms. But this can be up to 2 weeks, and hence the 2-week quarantine required or isolation required post-travel. The majority of patients, fortunately, will have mild disease. Estimates are about 80%. However, about 14 and up to 20%, depending on what studies you read, will require hospitalization, and 5% will require critical care. And those patients will be our focus tonight. And these are the patients that are somewhat the most important in the sense that they're the ones that will put pressure on our hospital and critical care resources. So, in terms of the actual clinical presentation for this virus, it can be quite variable. So this is aggregate data from several studies from China, Italy, and the US, showing that the three most common symptoms would be fever, dyspnea, and a dry cough. These are often present, but not always. Other symptoms that the patient may come with is GI symptoms, so that's something to keep in mind. I believe we had 2 patients who initially presented with GI symptoms and only later developed respiratory symptoms here at our center. And an interesting presentation is a change in the smell and taste, which could be up to 19 to 34%. Bear in mind that studies showing fever have included really low-grade fevers, such as in the 37s, but most patients present with fever at some point in their hospitalization or illness course. And one thing to note, the elderly and the immunocompromised may have atypical presentations. In terms of investigations, imaging may underestimate the extent of disease. I will show you an example of a patient who initially had imaging that was essentially normal and then later went on to develop changes. This is especially true for chest x-rays. Chest x-ray may underrepresent the degree of opacification that may only be picked up on a CT scan. What you'll see is usually bilateral, peripheral, and more often involving the lower lobes. There is increased interest in point-of-care ultrasound at the bedside in order to avoid transporting these sick patients who are under isolation to the radiology suite. Here's an example of a patient that we had at our center. The first x-ray shows the chest x-ray 5 days prior to admission to hospital. Patient was seen in the emergency department and had that x-ray and was thought to have some pneumonia and sent home. 5 days later, he represented, and you can see the more typical findings that we would expect with COVID-19. So again, chest x-ray may lag behind symptoms. Here's an example of another patient with confirmed COVID-19. This is a CT scan of a patient who initially did not have respiratory symptoms and presented with GI symptoms. And in this case, CT was instrumental in helping make the diagnosis. So you can see the pattern we talked about, bilateral infiltrates, more so in the posterior and lower lobes. So, this is just for interest, showing some images from point-of-care ultrasounds. These are not images from COVID-positive patients, as there hasn't been enough data in these patients published. The first x-ray shows some B lines, which you would expect in cases of pulmonary edema, consolidation, and that can be extrapolated to COVID-19 patients as well. The image in the middle shows you a normal liver and then lung. We call this hepatization of lung due to consolidation, as the lung has the appearance of liver. For the eMERGE guys in the audience, this was from an eMERGE, and there's also some free fluid. And the last image shows the dynamic air bronchogram, which again you can see while scanning, where you'll see this is easier demonstrated with a moving probe. However, you'll see your bronchograms kind of like you would on a X-ray, bronchograms between consolidated lung. So when we look at these patients overall, there's a few factors that are associated with more severe disease and mortality. One of these is advanced age. This was seen especially in a cohort of patients in Italy. Cardiovascular disease, diabetes, hypertension, chronic lung disease, kidney disease, increased BMI, Interestingly, some patients, even with severe disease, had no risk factors, about 0.6 to 0.9%. So again, when we look at prognosis, it is difficult to prognosticate which of these patients will do well and which will not. The following factors have been associated with worse prognosis, and the two highlighted, lymphopenia and elevated D-dimers, have actually been correlated with increased mortality. Now, we've gotten questions, well, should we test this in every single patient? And I don't think so, unless we're in perhaps a surge situation where we're really having to ration critical care beds, and we're trying to use every tool possible in order to ration these beds. But I don't think this would help you in the day-to-day management of these patients. So, moving on to case fatality rates, these are very difficult to calculate, and these vary widely between countries and what has been reported. Again, this will depend greatly on your denominator, which will depend on whether you're testing widely or testing everybody, or whether you're only testing symptomatic patients. In terms of your numerator, this will depend on your healthcare system, your hospital capacity, and your number of things like ICU beds and ventilators. Overall, it appears that the case fatality rate has been estimated about 1 to 2.3%, about 20 times the seasonal flu for those people that say, oh, it's just like the flu. But again, remember, these rates are evolving, and they're influenced by factors such as rate of testing. This is from a recent paper in the Lancet Infectious Diseases. It just compares the mortality rate between SARS, COVID-19, and influenza, and divides it up by different age groups. So you can see, as expected, in all of the three diseases, the mortality is higher in the higher age groups. The mortality of SARS was much higher than for COVID, which again is much higher than for influenza. But you can see that the mortality, even for younger people, is not insignificant. And again, mortality in the ICU, especially with patients who develop ARDS, which a large majority of them that end up in the ICU do, is about 50%, and if they need mechanical ventilation, about 66%. There was a small paper that indicated it was about 80%, and I had people say, well, most of them just die in the ICU. But again, this varies across the literature, and I think these estimates are probably safe until we have more data, which is, as mentioned, coming out daily. So one brief thing about testing before we get into the actual ICU management, which is the bulk of this talk. So we have to be careful with the sensitivity and sensitivity of the nasopharyngeal swabs. Again, variable numbers have been published in the literature, estimates of about 70% for sensitivity and 97% for specificity. So what this means is there's a possibility of a false negative. So one of the methods recommended in the guidelines and what we use here is that if the pretest probability is high, so what I mean by that, if you're pretty sure your patient has COVID-19, we retest these patients in the intensive care unit, and usually by sending a sputum in addition to the nasopharyngeal swab. Until then, we keep them on isolation. Okay. So we're going to start talking about a little bit the management of these patients when they get into hospital, and then we'll follow their progression, what happens when they get into the intensive care unit. This is from the Surviving Sepsis campaign, published recently on the management of these COVID patients, and they have three types of recommendations. So they either recommend a treatment, they advise us to consider it, or they do not recommend it. And this is all based on level of evidence. So for example, for COVID-19 patient that may come to the hospital with hypoxia, you need to decide, does this patient need intubation, yes or no? And we'll get to some tools to help you decide that. Following this, you need to decide if they are comfortable on their supplemental oxygen that you're using, so usually starting with nasal prongs. If yes, these patients need to be monitored very closely because they can deteriorate suddenly. We're very fortunate here to have a respiratory floor with pulse oximetry so that patients can be monitored. And again, early involvement of the critical care outreach team or intensivist is prudent if you have that available. Following this, if the patient fails supplemental oxygen, you can consider, and you can see there is a consider high flow nasal cannula. And again, if the patient does not tolerate this, you would consider them for intubation. At the beginning, a lot of the guidelines counseled against using non-invasive positive pressure ventilation or BiPAP. However, it can be considered as long as the patient is monitored closely. What you don't want to do is get into a situation where you put somebody on BiPAP and then they crash and you have to do a stat intubation, because as we'll talk about, intubations in these patients need to be planned and coordinated with all the people and equipment available to minimize both morbidity for the patient and also risk to the healthcare team. So that is a bit of a summary, and then we'll go break it down point by point and go over some of the things we've talked about. So for acute hypoxemic respiratory failure, as we've mentioned, if you have available at your center, high-frequency nasal cannula is suggested. And again, a trial of positive pressure ventilation can be considered as long as the patient is monitored closely for impending respiratory status, for monitored closely for worsening and intubation considered. Remember, both of these procedures are considered aerosol generating, and negative pressure room is recommended. Okay. These are two other considerations for patients prior to needing intensive care. One of them is CPAP. The thinking with CPAP is that it provides the equivalent of PEEP and may help open up some of those alveoli, as we'll talk about, because a lot of these patients have ARDS, they have collapsed alveoli, they have significant hypoxia, and the thought is that CPAP may be able to help, again, considered aerosol generating. And the other point here is proning. So when we get to the ICU management, we'll talk about proning, but what I mean here is proning patients while on the floor. I first heard about this from a colleague from Spain, one of my classmates from Peru, and they mentioned that they were doing this to try to minimize the number of patients arriving to the intensive care units at the same time. There's no protocol per se, and I did find only one paper that mentioned this by Sun and Al in Annals of Intensive Care Medicine in March of 2020 that talked about in China using this on the wards to try to improve oxygenation with good success. There's no protocol per se, you just ask the patient to lay on their stomach. And the idea is to improve the homogeneity of the lung, as we'll talk about later in the intensive care part, and improve oxygenation. So let's say you've tried all of the above and the nasal prongs didn't work, you've tried your high flow nasal cannula, the patient is still hypoxic, and now you're considering intubation. So in COVID-19 patients, the most common scenario for requiring intubation is hypoxia. However, you may also be faced with worsening hypercarbia, decreased level of consciousness, or some other reason to intubate them, such as airway obstruction. I think before intubating patients, I think it's really important to have goals of care discussion with these patients and involve the intensive care unit early in order to determine that the right patient gets in the intensive care unit and that we are maximizing the benefit for that patient. So assessing the patient, assessing whether intensive care management is appropriate, and then in a controlled fashion bringing them down to the intensive care unit for intubation. Or if you have a negative pressure room on the ward, potentially doing it there. So very briefly, in terms of intubation for these patients, there is clear guidelines out there saying that you should try to use the best possible persons, so persons skilled in airway management. These patients don't have a lot of reserve, and post-intubation hypoxia is common. Using a video laryngoscope, the idea being to remove the intubator from the patient and minimize the aerosol, minimize the people in the room, everybody of course wearing appropriate PPE, and intubation being performed in a negative pressure room. Using rapid sequence induction, RSI, which we'll talk about in the next slide, and again minimize bagging and connecting the patient directly to the ventilator and looking at a capnography curve on the ventilator as opposed to what we're used to, where we look at the change in color for the CO2 detector. Again, there's a lot of hospitals are coming up with so-called intubation teams, but I think no matter what method your hospital chooses, some of these points here are quite important in order to minimize the risk both for the patient and for the team. In terms of RSI, again, everybody will have their own protocols, but basically you need an induction agent, a paralytic, in order to minimize coughing. And then again, these are preset doses, and often when you take away the work of breathing, these patients are sometimes hypovolemic, having been sick for a few days. You may see post-intubation hypotension. And in this case, it's important to have pressors available, either an infusion, but in this case, phenylephrine pre-mix that you can push to counter this. So in this scenario, having just intubated these patients, sedated them, paralyzed, you will likely need some kind of sedation. Again, a lot of them will have ARDS. In general, in the intensive care unit, you don't need to sedate every patient, and some are quite comfortable in mechanical ventilation, but these patients will require some sedation. Our go-to is usually fentanyl to start, propofol if the patient can tolerate it pressure-wise, and then you have the option of ketamine if that's available at your center, as well as midazolam. We try to avoid midazolam at our center due to the deliriogenic effects, but again, you may find, and we may find as a hospital and provinces, if the pandemic progresses, some of these may not be as available, so we have to be flexible. So you can have a few choices that you're comfortable with using. Again, we do not routinely paralyze patients, and we'll get to paralysis in the context of these patients. So this was probably the most common question I got in the last few weeks. So ventilation, ventilators, how do we approach this? So I try to simplify this in very, very kind of simple, basic, easy to understand. So when you think of ventilation, you have your mode where you're doing all the work for the patient is not doing the work or not breathing spontaneously, or the patient is. So assist control, which can be pressure control or volume control, at our center we happen to use a lot of pressure control, versus pressure support. So with assist control, the ventilator delivers the breath. The patient may not be breathing spontaneously at all, and you will set a respiratory rate and the ventilator will deliver the breath. In pressure support, the patient is breathing spontaneously and you're supporting them with each breath. And we'll get to a little bit more of that later. And then you have some other modes which are combined, such as SIMV, and in a few slides we'll talk about APRV as well. So, as we mentioned, the mode of ventilation can be spontaneous or not. In a spontaneous mode, the patient initiates the breath, the ventilator supports it, and again, in AC mode, the ventilator initiates the breath and delivers the breath, either pressure or volume control. This doesn't mean the patient cannot be also breathing above the ventilator, but the breath will be supported by the ventilator. If the patient initiates the breath, the ventilator will support it with the parameters you set. And again, one of the main differences is also how the breath is triggered. In the AC mode, it's mechanically triggered. The ventilator will give a breath every at a rate that you have set. But in the pressure support, the patient will trigger it. The ventilator will sense the flow of the patient trying to make the effort and support that breath. So that is just a little bit on the basics, how to sort out what kind of ventilation, and then we'll get into ARDS, which is, I think, what most of these patients will come in with, and where ventilation strategies will become most important. So in 2012, the new Berlin definition of ARDS came out. So this is a long-winded, taken from that paper. It's an acute, diffuse, inflammatory lung injury leading to increased pulmonary vascular permeability, increased lung weight, loss of aerated lung tissue, causing hypoxemia. And as we've seen in those images that we earlier, presenting with bilateral radiographic opacities, increased advenous mixture, and then increased physiological dead space. Or, put more simply, ARDS requires acute onset, bilateral opacities, and then respiratory failure not fully explained by cardiac failure, fluid overload. Some of those images you have seen can be explained with congestive heart failure. So that needs to be ruled out. Sometimes you can have both, but I think that's, again, where point of care echo comes very useful. In terms of dividing ARDS into mild, moderate, severe, we use the PaO2 over FiO2 ratios. So the PaO2 can be obtained from the arterial blood gas, and then your FiO2 is your fraction of oxygen. So we would check this daily or more frequently, and we will use this to determine the treatment such as proning, etc. So again, here is the criteria for mild, moderate, and severe. And remember, this is on a PEEP of at least 5. And we'll talk about PEEP in a moment. So this schematic just shows us the pathophysiology of ARDS. So you have inflammatory cells, you've got fluid, and you have enlargement of the diffusion gradient between your alveoli and your vasculature. So that is why you have decreased diffusion of oxygen, hypoxia. What also happens, the alveoli collapse. So you create ventilation-perfusion mismatch, dead space, worsening hypoxia. And so then what happens, you get what's called heterogeneity in the lung. Some of the alveoli collapse. The remaining alveoli are now being overventilated by the tidal volume you're giving, leading to more inflammation. So you get into a vicious cycle where you're trying to help and causing more inflammation and making things worse. So a lot of the strategies we'll talk about in ventilation in ARDS are actually designed to prevent more inflammation. The treatment in ARDS and in COVID patients with ARDS is really supportive and preventing worsening of more damage. So this is just summarizing what we just talked about. You have alveoli flooding, the alveoli collapse, you have less aerated lung, leading to worsening hypoxia, ventilation perfusion, mismatches and heterogeneity, and increasing intrapulmonary shunt, again, all worsening the hypoxia. So, having talked about ARDS and understanding kind of a little bit of pathophysiology, we will go over some of the strategies we use to manage these patients and treat them with patients with ARDS. So the first thing is low tidal volume ventilation. Second is optimizing your PEEP and trying to minimize your oxygen. And then we'll go through each one of these one by one in the following slides. So starting with low tidal volume ventilation. So different guidelines you'll read will say 4 to 6 or 4 to 8 milliliters per kilogram. This is a predicted body weight, not or ideal body weight. So there's formulas, they're different for women and men, and they involve measuring height, plugging it into a formula, and coming up with the predicted body weight so that you can use that for your tidal volume ventilation. Another thing you want to do is limit your plateau pressures to less than 30. So this is going to be actually the pressure that the alveoli are seeing. So that's the one that you are worried about. So people say, well, what is that? You need to do an inspiratory hold. So this plateau pressure means that there's no flow. And I'll show you some examples on a ventilator picture. So again, once you've calculated your predicted body weight, and again, when I say we are very lucky at RVH to have excellent respiratory therapists who are experts at managing the buttons, so to speak, of the ventilator, and we work together to determine plans for these patients. But I don't think anybody will be asked, at least at our center, to manage the ventilator itself. But I think it's very important that you understand the pathophysiology and the ideas behind some of these treatments. So once you've set your tidal volume, or made sure that you're not going past this tidal volume and that your plateau pressure is less than 30, the next thing we're going to look at is the PEEP. So your PEEP is your positive end expiratory pressure. So the way I like to think of it is almost like a CPAP. So that's a pressure that doesn't change. Even when the patient exhales completely, this pressure is there constantly in the background. And the idea is to try to keep those alveoli open. Again, there's several ways to determine this. I'll show you some PEEP tables. Our respiratory therapists will often do a decremental PEEP trial, looking at the compliance of the lung, setting the PEEP high, and then slowly decreasing it until they find a PEEP at which the compliance does not change anymore. And then they'll usually set at 1 or 2 higher, and that will be your PEEP. Again, compliance will change, and it is very important to assess this frequently so that you're using the right amount of PEEP. If you're stuck and you're at a center where you don't have this and you don't have respiratory therapists, you can play around with a PEEP to adjust your SATs. That might be a more crude way to do it, but again, you may not have all that help depending where you practice. In terms of a ballpark, people say, well, what do I set it at? The minimum of PEEP in any patient is usually 5 to overcome the resistance of the endotracheal tube, but in these ARDS patients, 10 would be a safe starting point, higher if there's obesity or other factors you might have to consider. Here's an example of the ARDS PEEP tables. Clinical trial comparing the lower PEEP to higher PEEP strategy found no difference in mortality, so we would go with the lower PEEP strategy. But just for those who are not used to high PEEP, you can see that when you get to really high levels of oxygen, the PEEPs are quite high. And I think that's one of the things people are sometimes surprised at when they look at these tables. So here is an example of ventilator settings. Thanks to one of our respiratory therapists, Jesse and Marcy, who helped me set this up. This is on a training ventilator. So this could be an example of what you may see after having intubated this patient. So here we are, we've intubated the patient. Patient is somewhat hypoxic. So you can see in the corner here that the oxygen is 100%. Until you've stabilized the patient, it's a safe bet to start them at 100 and wean them as tolerated. We've picked an arbitrary PEEP of 12. Again, before you've had a chance to check your PEEP tables or do your decremental PEEP trial, that's a reasonable start. You can see here that this is AC ventilation that we talked about. So we are doing the work for the patient. We're setting the respiratory rate at 22. And you can see that you have and you can see that the actual respiratory rate, you'll see it up here. So this patient, which was here a ventilator connected to a rubber lung, is actually breathing above your set rate. And then the pressure is 22. In the upper corner, you will see something called peak pressure. And if you wanted to look at that plateau pressure we talked about, you would have to do what's called an inspiratory hold. This picture doesn't show it, but there's a button on the ventilator that says inspiratory hold, and that would allow you to see the plateau pressure. So that's just to give you an example practically of what we mean when we talk about setting the PEEP, setting the FiO2. And then you ask, well, why do you pick this pressure? Remember, you can set the volume or the pressure. You can't set both. So in this case, we're changing the pressure and looking at the tidal volume, which you can see up here, 328. This would have been calculated using your predicted body weight and using your 4 to 6 mils per kg. So what we'll do is we'll adjust this pressure to fit our tidal volume and make sure we don't go over our recommendations. And again, as our compliance changes, either for the better or worse, you may need to adjust that. So once you've done all that, you've optimized your PEEP, you've optimized your oxygen, and your patient is still hypoxic, you would do your blood gas, and if you determine that the patient has moderate or severe ARDS, you may consider proning. So so this is one of the recommendations from pretty much every guideline on this. So for moderate to severe ARDS, prone ventilation for 12 to 16 hours. Again, you'll see recommendations 16 to 20. At our center, we usually use 16, and then you flip the patient supine. The theory here is that this will improve the lung homogeneity. Remember, often it is the posterior areas of the lung that are more consolidated. So by turning the patient over, you may offload those areas from the weight of the heart and the anterior lungs and improve oxygenation to those areas. It does not change significantly the perfusion, so you're going to have perfusion to the lung, but you're going to increase which areas are actually ventilated. This may also help you in terms of decreasing the stress on the good lung, so to speak, because remember, we talked about with the same tidal volume, if you have severe consolidation, you are now ventilating a smaller lung, so-called baby lung theory. And by proning the patient, you may be able to make the lung more homogeneous and improve your oxygenation, and again, very importantly, prevent further damage to the good parts of the lung. So, and again, you would assess this several times a day. You would check your ratios of your PaO2 to your FiO2 to determine when to stop proning. So next topic that often comes up is paralysis. We used to be much more liberal with paralysis until a few trials came out and did not show mortality benefits. So again, if you're proning patients, they need to be sedated and paralyzed. Otherwise, routine paralysis of ARDS patients is no longer recommended. This can be useful in the case of ventilator asynchrony, so the machine is delivering the breath, the patient is using their breaths, and by the machine cutting off the patient's breaths and vice versa, you may have increase in your tidal volume, and you might not be able to meet your tidal volume targets that you've calculated. Other reasons you may want to paralyze somebody if your airway pressures are too high, or again, if you're considering proning. Remember, with paralysis, especially if you're also using steroids, there's increased risk of critical illness, myopathy, and neuropathy. But again, these patients are in ARDS, they're hypoxic, so you may need to be using this. But just remember that it's no longer routinely used. You can use intermittent boluses, and if you are using an infusion, again, reassess after 24 to 48 hours. Okay. So you have your intubated patient, you are doing your proning, you have optimized all your ventilation strategies, and now what are some other tools you can consider? One of them is something called a recruitment maneuver. So what this means, inspiratory hold for 30 centimeters of water for 30 seconds. In practical purposes, in speaking with our respiratory therapists, what they'll often do is flip the patient to pressure support, set the pressure support to 0, and put the PEEP to 30 and hold it for 30 seconds. Again, if you think about it, this may increase your interthoracic pressure, and so you have to watch for hypotension, especially in the hypovolemic patient. So if you're going to try this, I suggest standing nearby. And again, you have to watch for barotrauma, so something like a pneumothorax. So there's a small chance your patient can get unstable after this maneuver, but if there is any recruitable alveoli, this may help improve your oxygenation. Okay. So, proning, you've done your recruitment, patients being proned, and you're still struggling. So one of the kind of tools we use is something called permissive hypercapnia. So if you think of your minute ventilation as your tidal volume multiplied by your respiratory rate, you have a limit to what you can do with either one of these. Again, there's only so much you can increase your respiratory rate before you start getting what's called dead space, and there's only so much you can increase your tidal volume before you start going over your targets. So again, what we do is allow the CO2 to rise up to about a pH of 7.2, as long as you're not having intractable hypotension. So, as mentioned, this will help you prevent excessive respiratory rate and going over your targets, because we're so used to making the numbers perfect. So, the pH is 7.2, the carbon dioxide has risen, we have to increase the ventilation. But again, this is one of the strategies in ARDS to stay within your targets. This is something down the line, very at the bottom of the line. So all of the above maneuvers have failed. Some of the guidelines have a consider recommendation of inhaled vasodilators, short trial only as a rescue. And then another method you may see talked about, or you may see it in the intensive care units, is airway pressure release ventilation. Quite an interesting method of ventilation that's kind of the opposite of what we normally do. So what we do here, we keep the patients at a very high baseline pressure, or very high PEEP, if you will, at about 30, and then every once in a while we allow them to passively exhale. And so what this theoretically does is keeps those alveoli open, and improves oxygenation. And again, as a last resort for centers that have this, you can refer the patient for ECMO. This is in very select centers, very limited number of beds, and usually in patients without comorbidities and younger patients. Better to, again, call early while the patient's still stable enough for transport. So that's a bit of a crash course on ventilation. And again, the purpose of this talk is not to make you an expert in managing the ventilator and ventilation, but just to give you some background in how we approach these patients, how we think about them. And again, it's a team approach between the physician, the respiratory therapist, and the nurse to put all those things together and try to optimize ventilation, oxygenation for these patients. So looking at those other things we mentioned at the beginning of this section, there's some other things you can try to do to support these patients through their illness. And one of them is the so-called fluid restrictive strategy. Again, this was emphasized strongly in a lot of the guidelines for management of COVID patients, but what they found is that by following this too strictly, people were ignoring the fact that some of these patients came in hypovolemic, in renal failure, having been sick at home. So you have to make sure that the patient is not severely hypovolemic. But the idea being that you try to use some measure of fluid responsiveness. So what I mean by that is try to see and sort out in your head, is this patient wet or is this patient dry? Some of the tools you have at your disposal would be point-of-care ultrasound, stroke volume variation, measures of perfusion such as lactate. Oh, sorry, that moved forward a little bit. Here we are. Again, in the intensive care unit, consider ordering something called total fluid intake as opposed to ordering an IV fluid rate, and then the next day feeds get added to that, and then the patient receives some IV antibiotics, and before you know it, they're getting liters of fluid that you weren't even aware of. And again, assess for diuresis if needed, and sometimes even dialysis if you cannot remove the fluid with diuresis. So the next step would be pressors. People were asking me, well, what pressor should we use? And if you had to remember one pressor, it would be norepinephrine or Levophed. The dose ranges are quite high, and there's no theoretical max. The dose ranges from 0.1 to 0.4 mics per kilo per minute. Most common range that we use in our unit would be about 2 to 20 mics per minute. But again, there is no theoretical max per se. It's dependent on the weight of the patient. If you need a second pressor, the pressor of choice would be vasopressin, and that one does not need titration and can be added at about 2.4 units an hour if you have escalating doses of your Levophed. Again, moving down the line and getting more complicated, if you have signs of cardiac dysfunction, you can consider adding dobutamine. And remember that a large proportion of these patients have myocarditis, cardiogenic shock, and this needs to be investigated. There's just some tools.
Code white to GC Charlie, code imaging washroom, code white to GC Charlie, imaging washroom, code white to GC Charlie, imaging washroom.
Code white intermission there. So coming back to this, again, just a roadmap for dealing with hypotension in these patients. And again, this is one area where steroids can be helpful if you have refractory shock, adding steroids to your two-pressor regimen. If you do not have norepinephrine or vasopressin, the guidelines for COVID and hypotension recommend epinephrine or vasopressin. Dopamine in head-to-head trials has been found to be more arrhythmogenic, unless you have specific circumstances, such as a severely bradycardic patient. And again, a MAP target of 65 for titration. Okay. Speaking of steroids, this was a conditional recommendation in the SCCM guidelines against the use of steroids in patients with COVID due to the risk of, or theoretical risk of prolonged viral shedding. Again, if the patient has ARDS and you've tried some of those maneuvers we talked about, you can consider adding steroids, as well as in refractory shock. In terms of therapy, there is no proven therapy in patients with COVID. At the end, we'll get to a few experimental treatments. But for the most part, you can consider starting empiric antibiotics, for example, ceftriaxone, azithromycin, as long as this is assessed daily and cultures are followed and de-escalation performed based on cultures. This was a recommendation to check for influenza and consider Tamiflu. However, we're getting out of influenza season, and I understand there's a shortage of these swabs, so this can be on a case-by-case basis. If you suspect that the patient may have influenza, may have been exposed to somebody with influenza, you can consider checking this. And remember that they have found that a percentage of patients with COVID also have pneumonias or influenza, so the presence of one of these does not exclude COVID-19. Okay. This here is just a summary of everything we've just talked about. Again, I really do like this Surviving Sepsis Campaign guidelines for the management of COVID. There's many other guidelines, and I've listed some references at the end of the talk. You will have access to these slides, and you can refer to them. This talk I would consider a primer for this. Each of these topics can be a talk in itself. Again, this just summarizes what we've talked about with ARDS. So when you have mild ARDS, you will do your basic maneuvers of keeping your tidal volume low, keeping your plateau pressure under 30, ruling out bacterial infection, not over-oxygenating the patient. And then again, the recommendations for fluids and steroids are considerations. And the data for steroids is, again, very uncertain because it is not recommended in COVID patients, but there is some recommendation for ARDS, so you have to be careful. Again, as we move past to moderate and then severe ARDS, the recommendations increase. So again, recruitment, considering steroids, and you can see that we cannot give you exact recommendations because they're all considerations on a case-by-case basis. And again, at the end of the line is your VV ECMO, which is your rescue maneuver. This has received a lot of press and has been in the news quite a bit. So treatments for COVID-19. At present, there is no therapy that's uniformly recommended for this. The treatment for COVID-19 and the intensive care unit is supportive. There are several clinical trials, and hopefully we'll have results soon. But for now, if you are going to use one of these agents, at least at our center, we recommend consultation with an infectious disease physician. And these are just to show you some of the possibilities that you've all heard about: the antiviral agents, the anti-malaria medications that have been promoted, and medications used in HIV and IL-6 inhibitor. So going back to our case that we mentioned at the beginning of the talk, so this patient did quite well, extubated after 4 days, transferred to the ward day 8, and discharged home day 11. All of the cultures were negative, and this patient did not have cardiac dysfunction. A lot of the patients that are ending up in ICUs do have prolonged courses. They may stay in the ICU a couple of weeks, which again makes it very difficult in the centers that have had high volumes of these patients because they do not have a short length of stay. This patient, like I said, did well. A couple of things just to mention. We're not going to go into this in detail. If you do have a patient with refractory shock, consider HLH. Again, you may see a drop in platelets, you may see high fevers, you may see organ dysfunction. You will want to check your inflammatory markers such as ferritin and ESR. And again, there is some data that anti-inflammatories can be considered in these patients. So this is when you may want to consider your steroids, potentially even escalating to IVIG or your IL-6 inhibitors, again with consultation. And the other thing that we're seeing more and more in the literature is that these patients have a much higher rate of thromboembolic disease. Some people are even suggesting that we may want to anticoagulate them, but there is no recommendation at present, but just something to be aware of. And they're finding the rate of thromboembolic disease to be high without evidence of DVTs. So they're having, from the inflammation in the lungs, they're having pulmonary emboli. So, in summary, hypoxia seems to be the main reason that these patients get admitted to the ICU. A large percentage of them have ARDS. Unfortunately, at the moment, at least that I'm aware of, at the time of this talk, there's no proven treatment specifically for COVID-19, and supportive care and to the best of our ability, evidence-based management of the associated ARDS may give this patient the best chance of survival. And again, remember, these are unprecedented times. There was 600 papers, I believe, published in the first 2 months, and the evidence is rapidly changing. So trials of these medications are ongoing, and we may hear about them soon, of new treatments or evidence for or against known treatments. And again, these are just some of the references that I've used, and then a few resources that you may find helpful, such as this University of Toronto ICU training guide. EMCrit is a blog that combines emergency medicine with critical care and has some great background information. The World Health Organization has guidelines, again, on the management of COVID. And for those of you who are looking to explore point-of-care ultrasound further, this is a website from Western University that has a lot of videos and instructions if you're interested. And I think with that, I will stop here, and with the help of Dr. Chris Martin, we're going to see if there were any questions during this presentation. And again, this was just a primer. Feel free to email me if you have any questions, and if I don't know the answer, I will try to find out for you.
Okay, well, thanks very much, Anna. Sorry, that's really loud. That was a great presentation, very thorough. There's some questions here on Slido that I'm going to read out to you. I kind of respond to a couple of them that were like based on blood gases, but the first one is going to be, I think you answered this question. So when would you, there's no evidence, but when would you consider using antivirals for a patient with COVID-19?
Luckily, we have Dr. Diodato here with us, our infectious disease specialist, and we will defer that question to him. I personally wouldn't without consultation with infectious disease.
So at this point in time, I think in the absence of looking for studies where you can enroll your patients, WHO is conducting global studies, I think under the global term of solidarity, adaptive randomized controlled trials, where they actually have sometimes 3 and 4 arms, each of which are testing some of the antivirals and anti-inflammatory agents that Dr. Egrich showed. And so at this point in time, I wouldn't recommend starting anything just on a case-by-case basis. We certainly wouldn't do that. As far as the availability goes, for example, for like using something like remdesivir, I'm not sure exactly how you get a hold of that drug. You might have to ask for compassionate release, and I'm not exactly aware of the process of how to do that. Tocilizumab and Coletra you could probably do because we have Coletra, and obviously we have potentially chloroquine, hydroxychloroquine. So I suppose if you wanted to do it, you could. I've been recommending against using any of these medications outside of study enrollment.
Okay, and so the next one is going to be so high flow nasal cannula is okay for use, and I think that most societies agree that it's probably not as aerosol generating as initially thought. And however, where should we be using this in the hospital? If someone does go on high flow nasal cannula, is it okay to be used safely in a ward, or does everyone have to be in a negative pressure room?
I think, and you guys can correct me if I'm wrong, in our center we are using it in negative pressure rooms. At last I checked, but that might have changed. The recommendations change very often here.
Yeah, and because it is listed by the province as an aerosol generating procedure, whether you believe it or not, you have to try to put them in a negative pressure room. Now, of course, everyone's going to run out of negative pressure rooms, and if you don't have one, then you should put them in an isolation room, so a room that can be closed off, and all staff should have an N95 and a mask. So if you have a negative pressure room, use it. If not, then do your best. They just shouldn't be in like a ward bed with a curtain separating the patients, same as the non-invasive patients. All right. Next question we have. So, Dr. Egrich, how often are you doing ABGs on intubated patients?
That really varies from patient to patient. One of the other things you want to do in this COVID outbreak is minimize blood work and minimize testing, again, to minimize people having to go in the room, to minimize exposure to your staff, and also to minimize use of PPE, which, as we all know, is in short supply. So there is some patients I will do daily, some patients I'll do twice a day, and the odd patient that is really critical, I may do every 6 hours. These are the ones that I'm considering referrals for ECMO. That would be very rare. I would say if I had to give you an average, in these ARDS patients, twice a day would be what I would do. And I don't know if my colleagues would do something different, but that would be my approach.
No, I think that's, I would agree with that one. I think we traditionally do in the morning and then when any change the ventilators, but like, I think you really have to have a good reason to do it, especially if you're, again, we want to decrease staff are going to be pushed, the labs are going to be pushed. So you really only do any kind of test in this environment if you're actually going to act on the results. And I mean, we should always do that, but I think even more so now. All right, the next question here. Sorry, I was going to bring it up here. Is so how long is a negative pressure room needed once someone's intubated, and what PPE is required?
This one we are going to defer to Dr. Diodato, who's in charge of that at our hospital.
Once someone has been intubated, it is on a closed circuit, we generally put them under droplet contact precautions in a regular room. That is, we do not keep them in a negative pressure room. Like many other centers, we recognize there's always the possibility of ventilator disconnect, but given the short duration of anything like that and the particular properties, we don't feel that's a high enough risk aerosol generating activity that warrants necessarily someone going into a room with additional N95 precautions or being in a negative pressure room. Extubation is considered a aerosol generating medical procedure, so certainly on extubation it would be ideal if the patient was in a negative pressure room, along with wearing N95 personal protective equipment. But post extubation, it varies on what's happening with that patient. I mean, most patients seroconvert, that is, they develop COVID specific humoral antibodies that should be immune by about 14 days, even though many of them still have molecular testing that remains positive up until the time of discharge. Finding RT-PCR tests that are positive in patients doesn't necessarily mean ongoing infectivity. It could just mean that there are virion particles around, but they're not necessarily intact virions that could cause infection in healthcare workers or close contact. So, it's an evolving thing, and hopefully as we will have serologic tests that come online, we'll be better able to make more relevant decisions of when we can discontinue aerosol precautions and even droplet contact precautions. We do have de-isolation protocols, but many of these are based on resolution of symptoms and molecular testing, that is, having serial molecular testing that's negative.
So there's another question about the convalescent plasma, and you have a slide on it, but what's the thought on that, and is it something that you'd ever try, or can it be tried outside of a trial?
I don't think it can be tried outside of a trial. I think that it's an idea that shows a lot of promise. It logically makes sense to me, but I don't think I would not use it at this point, and I don't think it could be tried outside of a trial. Julio, do you have any other thoughts on that, or is that what you know?
You can. There is a hotline to the FDA that you can make a specific request to the FDA to access convalescent plasma, but it is, I think, part of enrolling your patients in a trial.
Yeah. Unfortunately, as much as we want to use some of these things, I think for the moment the recommendation is that they all should be used as part of a clinical trial. And I think in Canada there's some great trials going on at the moment. I'm not aware that we are a site for any of them. I don't think so, but hopefully, like I said, more data to be coming soon.
Okay. I'm sorry. The next question, if I can get it up here.
By the way, thank you everybody for your questions. I had images of
this is good.
People in their kitchen making a sandwich and not really listening in. So thank you very much for your attention and your questions.
So this one's about proning. So who are the team members in protocol for proning, and is there a risk of loss of airway during this procedure?
We were very lucky that we started proning patients about 4 years ago, I would say. And initially, I think our protocol was based somewhat on London Health Sciences protocol. They have an excellent protocol online. I just re-reviewed it the other day. That's where I trained, so I may be a little biased. But we ourselves have our protocol. And so how we do it, you usually require about 6 people. Again, they may not be possible if we get busy. We require a respiratory therapist at the head of the bed. And again, there has to be one captain, so we take direction from that respiratory therapist about when to move and which way to go. And there is a physician present. So those two are our safeguards against if we should lose the airway. And of course, there is a chance you could lose it, but that's why you have people able to reestablish the airway present in person during proning.
And should the intubation teams be proning people right away, or should there be a trial of conventional supine ventilation first?
I would say there should probably be a trial of conventional supine ventilation. It gives you a chance to optimize things, and you may find you may not need proning. With the proper PEEP, with a recruitment maneuver, with your optimization, you may find you may avoid it. And as much as proning is helpful, and we do advocate early proning, it is very labor intensive, and as the intensive care units get busy, this is going to get harder and harder. So I personally would recommend at least a short trial of trying to optimize things with the other tools we talked about.
Okay. Next question about high flow nasal cannula. The question was: are you using a PF ratio or the ROX index to decide A, who's eligible, and B, who's being successful with it? So to put it on, would you use because a PF ratio is a more clinical decision? I'll start with that one.
I would say it's a more clinical decision. And again, as I said, initially the guidelines said, oh, well, if the patient is on 6 liters, you must intubate them. But there's some recent data showing that you have to use a more of a holistic approach to decide when to intubate these patients, because often they're hypoxic, but they sit there comfortably hypoxic, if you will. They're not distressed. Their work of breathing is not increased. So I think it should be a case-by-case clinical decision.
And I'll maybe tackle the ROC index one. If that's okay, the ROC index is a oxygen saturation FiO2 over your respirate. So it's a calculation we use you can use to decide who's going to do well, and if your ROC score is greater than 4.88 at 2 hours, your risk of intubation is low. But if your ROC score is low, indicating kind of your respirate is really high and your sats are low, then obviously your risk of failing is high. To be honest with you, this is a new score that I've recently learned about. I haven't started using it, although I will be using it. We're using it at Orange for determining if people are going to transport okay on high flow nasal cannula. It seems like a nice objective measurement to use because it does take into account. However, I think in isolation, I think you still have to look at, somebody may have a reasonable respirate, but they just may look tired. So I think that that's not the only thing that I would use, but definitely very helpful to have an objective number to say, this person has a high likelihood of failure with high flow nasal cannula, because as you alluded to before, you don't want to wait till their sats are 70 to intubate them. I've intubated 2 of these patients already, and they do desat very quickly. So you want to make sure you've got some reserve left, and you don't want to intubate them, in haste. You really want to have a good plan.
And on that note, I think this is a patient that you want to get ICU involved early, and I may move that patient down to our negative pressure room in the intensive care unit, set up my intubation people, set up my stuff, and then be ready to intubate them. But they may need to be watched if available in the critical care unit. Okay. And are there any ongoing clinical trials for COVID patients that we're involved in, either in this hospital or in our region currently? Defer that to Dr. Didiodato again.
Sorry, do you mean are we recruiting patients? We're just trying to organize now to become a site for some of the WHO studies. So that's in process. But we're not actively recruiting at this time.
Okay, next question. Any guidelines is for extubation protocols? And I'm not sure if this question is referring to when we extubate, which is a kind of Maybe I'll get you to just comment on when do we extubate patients in general.
Sure.
And then maybe a specific to these COVID intubations with regards to some of the techniques people are using to try to decrease the aerosolization at the time of extubation. So.
Okay. So we'll start first off, if it's a general question, when do we extubate? The best reference I refer you to is the A to F bundle. Again, this is kind of our guidelines for care in the ICU. So before extubating anybody, again, you make sure they're awake, that their GCS is appropriate, that their airway is okay. Again, I read some stuff about saying make sure you have a cuff leak before extubating these patients. They found that some of them do have airway edema. So that would be one thing I would recommend specifically for COVID. There is also a not insignificant reintubation rate in these patients, so they may be extubated and require reintubation. So definitely need to watch them closely. And then in general, you would do your spontaneous breathing trial, make sure that they pass, make sure that all of the above we talked about are present, do your cuff leak, and then extubate them. I've seen some stuff out of Toronto, extubating them in a paper bag to decrease aerosolization. We have not been doing that at our center. Again, we try to extubate them in a negative pressure room and ensure that all members are wearing proper PPE. But beyond that, I don't know if you can comment further, Chris, but I don't have anything else to add beyond that.
Yeah, I mean, I think that, there's always thing about these, clear bags and putting a hole in them. And I think with just like the intubation, that I think your best bet is to, again, have the best people in the room, well-trained, well-equipped with proper PPE, and do it the way you always do it. When you try to invent new kind of unique ways to do it without the proper training, I think the chance of a mistake is higher. So I would just recommend you probably do it the way you normally do it. Okay, next question is going to be, so, this whole 6 liters per minute thing, it seems like the pendulum swung away. Now, do you feel like we are kind of going to lean on the high flow and BiPAP a little more than the initial thought was, 6 liters a minute, they're above that, they're going to crash and intubate all of them. Do you think that's changing?
Yes, absolutely. So initially when the guidelines came out, we followed the guidelines, but what we're having now is practical experience. So initially people published guidelines, but now they're publishing case series and their experience from various centers. I don't think it will be practical, especially if you surge, to intubate every single patient. And what they're also finding that might not be beneficial for the patient. Again, as we've heard, the patient desat quite profoundly post-intubation. They may actually de-recruit. You're taking away some of their intrinsic PEEP when they're breathing spontaneously. So I think the pendulum has definitely swung, and I wouldn't use an arbitrary 6-liter cutoff. But what you might want to consider, especially if your hospital is taking care of these people on the floor, is involving your colleagues from intensive care, giving them a heads up earlier so that we can plan and follow these patients' progression. But I definitely do think the pendulum has swung to not following that as an absolute. And I think high flow nasal cannulas are playing a more prominent role. BiPAP, I'm not as sold on, but I think it is still an adjunct. Again, we have a limited number of ventilators, and they may be an important adjunct, at least in specific types of patients, especially ones with COPD as well, or things like that.
And I think there's a lot that's in the Italian literature that seem to respond to CPAP very well. So always worth a try. But again, I think as you said before, you really have to keep a very close eye on them in a very, they have to be in an ICU setting, of course, because they can deteriorate really quickly. Next question. In our COVID patients, and maybe some of the case reports and stuff that when we've been doing our reading, do you find the vitals don't seem to correlate with the clinical experience of the patient? So you've got a patient who's satting in the low 80s, but is on his phone texting and looks fairly relaxed, even though his numbers look terrible.
So my personal experience does not involve a large volume of COVID patients. Again, I am more comfortable, I think, with leprosy at this point with my diploma of tropical medicine. However, the published literature does seem to think that they're very comfortably hypoxic. And maybe, Chris, you can comment from your experience, having done quite a bit of ICU in the last few weeks.
Yeah, I think, and talking to colleagues in Canada with the same thing, we got intubated and they're SATs are 85, and you're like, they look pretty good, right? And so I think that is letting people push the envelope a little longer, but you have to keep a close eye on them. So I don't know why that is. I don't know why someone who's satting, 82 on a non-rebreather looks so good, yet if they had the same with a streptococcal pneumonia, they would look really crappy. I don't know, Julia, if you have any thoughts.
So a couple things that Anna or Dr. Igrig already brought up. One is Do they have microvascular disease, right? So are the D-dimers representative of microthrombotic phenomena in the lungs? So you're having VQ mismatches that are not necessarily that symptomatic. I mean, we've all seen lots of pulmonary embolus patients who look totally fine and their stats are 70% and they're blue, and they're talking to you in a very comfortable way. The other thing is that the other issue that Dr. Igric brought up, which is, are they vascularly replete in terms of being euvolemic, right? So are we creating VQ mismatches because we're trying to be very aggressive with under resuscitation, and so as a result we're creating VQ mismatches that otherwise wouldn't exist because they're actually hypovolemic. And again, that person should not be distressed because you've created a VQ mismatch that's resulting in worsening hypoxia.
Okay. So is there a role for proning in a non-intubated patient? You kind of touched on that. Do you want to expand on who you would choose to do this in?
So I think there is. Like I said, my first exposure to this was a text from one of my classmates who's in Spain, and when they got overloaded with ICU patients, they had to find ways to slow down the admission to the intensive care unit. Who I would consider for this, and it's been done at our center actually, is somebody, let's say, who you see increasing oxygen requirements. For example, they were on 2 liters nasal prongs, now they're on 4. We had a patient who was on Optiflow and was proned and had their oxygen requirements decrease. Again, there's very little data. I could only find a subset of one study, but it again makes sense because if these patients you can have ARDS and not be intubated. You can have hypoxia and not be intubated. So by the same token, by having them lay prone, you can increase the homogeneity of their lung and potentially decrease their oxygen requirements. So my plan when I do my critical care outreach week is to do this quite frequently and just try. Put them prone, to retest their oxygen saturation. I think the harm is so low that it's worth a try.
Yeah, and I think that you and I talked about this before. It's the key is they have to be able to prone themselves. So it's not like you're going to roll over a 90-year-old with who's got who's got on 50% oxygen. It's going to be the young, and in our N of 1 we've had here, it was a young in her 30s who would look very comfortable and could lay in her stomach like she was watching a movie and just happened to do with nasal canine. So that they have to be able to roll themselves back and forth, indicating they're pretty young and pretty able to do that. I'm going to try it as well. Again, the right patient.
Yes.
So another proning question. So if you are going to prone, and obviously if there is a loss of airway in a sedated and paralyzed patient, this is disastrous. Do you think intubation teams should be present and wearing PPE for emergent reintubation if needed?
Well, in our intensive care unit, all of us are very comfortable with airways, so we would be present anyways. Our protocol states that the physician must be present, so I think that is a good idea, and the respiratory therapists are very skilled at intubation here, so you will have a physician and a respiratory therapist in the room in full PPE, because for this proning we are wearing all the PPE. So I do think that's a good idea. And if you anticipate a difficult airway, I would have all my airway adjuncts right outside the door, ready to go.
Yeah, we always prone with the physician. It has to be there. That's our protocol. The other thing too is I think that if you're going to do this and you're not a center that's done them, make sure the first person you prone isn't a real patient. Like you want to practice on just even one of your colleagues, like get them to pretend they're intubated and just go through the procedure and practice it before you ever do it on a real patient. It should be very orchestrated, very slow, very deliberate. And if it's done right, the risk of extubation should be very, very low. And of course, like any of these other things, if you have any questions or concerns, you're at a center that doesn't have any experience, please don't hesitate to reach out to us. We've done a lot of it now, and we're happy to kind of guide you through it, especially with the virtual critical care.
Absolutely, but at the same time, I don't think people should be afraid of proning. To be very honest, our first prone patient was just proned by one of my colleagues before we had a full formal pro, because that was the last resort before arrest. So don't be afraid of proning. At the end of the day, it is simply turning a patient onto their stomach. There is things you have to watch for and areas you have to pad and kind of things that have come out of experience and data, but don't be afraid of it. At the end of the day, it's just turning a patient on their stomach.
Okie dokie. And all right, lots of concern about lack of ventilators. Is the concern as we're trying, I guess the first question is, how does the ventilator supply look given our kind of trends? Do you think we're going to run out of ventilators?
This one I will refer to you, Chris, as our chief and clinical director.
I have no idea. The models have been all over the place. The most recent one I saw from 2 days ago looked that we would need 60 ventilators by June, which is short of what we have. I think we have 40 ventilators currently. Given the shift towards trying to manage some of these we might just have to manage some of these non-invasively and high-flow nasal cannula as much as we can. Now, by June, though, I think that you will start to see more ventilators be produced and more come down the ventilator pool. Companies are working, and they will start pumping these ventilators quickly. So if we can hold off till June, we might be okay. So I think and by the triage plan for the province is that people will be shipped all over the province until there are no ventilators left. It'll never be a situation where, you're in Collingwood and, you're at a ventilator and we're out of ventilators here. But if there's a ventilator in Thunder Bay, guess where you're going? So I'm hoping not. I really hope that we have more ventilators than we need. And down the road, we're like, oh man, we had too many ventilators. But that's a way better problem than, we don't have enough.
And I think preventing, again, I didn't stress this, but this is something we are really trying to do. Excellent end-of-life conversations, goals of care. In an ideal world, we only want to admit people to the intensive care unit who will benefit from the intensive care unit intervention. So we have a very robust program at our center where we do good goals of care. The intensivists, all of us are very happy to help at any time if you're struggling with some of these discussions. So that's going to be one way to ensure that the people who get on ventilators are, so to speak, appropriate patient for that ventilator. And again, trying to minimize who you intubate with all those strategies we talked about. So the nasal cannula, the trialing of proning on the floor would be some of the strategies. And again, of course, the public health aspect of it, the flattening the curve and trying to slow down the rate of admissions to the intensive care unit.
Thanks. And can you comment on the incidence of COVID myocarditis? And is the treatment or mortality different if there's myocarditis and cardiac dysfunction involved?
Like I said, a lot of studies combine myocarditis and cardiac dysfunction. I think I've read up to 30%, and you can correct me if I'm wrong. I don't think the treatment would be too different per se. I think an echocardiogram would be essential to see what your LV function is doing. Beyond that, management with pressors, again, fluid management, I don't think you would do anything too different. I don't know if you can comment.
I don't know if it's depending on what the echo should be. You may find more of a role to introduce dobutamine if they need more cardiac kick. And I wouldn't be hesitant to, get a formal echo and reach out to, your either an intensivist or a cardiologist too. Sometimes we'll, get them to weigh in. And again, with, it doesn't just have to be a phone call, so they don't need to see the patient. But definitely mortality, I think, right. I think one study was up to 30%, but definitely once you get cardiac involvement, your mortality does go up. So hopefully we don't get to see too much of that. Is proning going to be allowed outside the ICU? I'm not sure this is an RVH question or not.
Sorry, go ahead.
And I'm assuming these are like when not like a patient on the floor that's intubated, but like a patient when the patient's in one of our surged ICU units. Do you think it's appropriate to prone people outside of the ICU?
Well,
proper.
It depends what your hospital surge plan is. Our